Hello, my name is Diana Artene. I'm a PhD in oncology nutrition, and at this conference, I presented a lecture on the preventive oncology nutrition for healthy carriers and BRCA1 and 2 breast cancer patients. And the reason I chose to do that is because these people have a lifetime risk of getting their breast, ovaries, prostate, or pancreas cancers. And that is why, because after they find out that they have these mutations, many healthy people choose to do behaviors that might not help them prevent cancer, like taking dietary supplements, or by loading up on fruits and vegetables, by not eating meat, or by forgetting all about sugar. And these behaviors are not preventive oncology nutrition, and we know that from scientific data. And in the lecture I presented, for instance, about dietary supplements, I presented to selenium, and we have data showing that while preclinical data shows a decrease risk with dietary supplements of selenium, when we look at a randomized control trial performed on the healthy BRCA1 mutation carriers, taking dietary supplements, for instance, leads and is correlated with a bit higher breast cancer incidence than the group evaluated that did not take the supplements. The same is true for loading up on fruits and vegetables. And while we all agree that these are healthy food for us, there is no difference between eating them, overeating them, and not eating them at all when we are talking about preventing cancer in BRCA1 and 2 mutation carriers, be that before diagnosis or after a cancer diagnosis. And one of the few prospective studies that analyzed the fruits and vegetable impact on the survival of more than 3,000 breast cancer patients showed us that the 5-a-day intake is enough to associate a 50% reduction of the breast cancer specific mortality, while the excessive intake of fruits and vegetables doesn't associate any oncological benefit. About not eating meat, some think that if they stop eating meat, they won't develop cancer based again on epidemiological data. But the external validity of epidemiological data is questionable because studies results can be easily biased, and because participants' answer can be influenced by recall bias and by semantics. And when we are talking about semantics, in most epidemiological studies, cancer is just a word. And if we separate these different diseases by localization, then we see that epidemiological studies researching the potential carcinogenic impact of meat show that red meat intake does not associate an increased risk of myeloma, kidney, prostate, ovarian, or hepatic cancers, and that excessive red meat intake correlates with an increased risk of lung, esophageal, and colon cancer. And for breast cancer, we only have some data showing that breast cancer risk might be decreased by reducing the quantity and eating frequency of fried, smoked, or deli meats, but moderate eating of meat, eggs, and dairy intake does not associate an increased breast cancer risk. And about sugar, some think that if, again, they will not eat sugar, their chances of their risk of developing cancer will decrease. But the idea no sugar, no cancer is logical only if we consider the Warburg effect as the only metabolic pathways available in tumors, which is not true. And for instance, we have preclinical data showing that HER2 positive breast cancers prefer to use amino acids and fats. We also have data showing that male breast cancer presents reduced Warburg effect, and The actual reverse Warburg effect was discovered in breast cancer, proving that stromal cells undergo the aerobic glycolysis while cancer cells maintain normal metabolism. So assuming that eating no sugar prevents cancer is an oversimplification that ignores both that because of intestinal digestion, no cell in the human body can feed on sugar, and that cancer metabolism is far more complicated than the old Warburg effect. Therefore, there is no food or diet that can prevent breast cancer, as the etiology is highly multifactorial. The only evidence-based nutrition-related factors involved in breast cancer prevention are obesity and alcohol. And while obesity increases the risk of breast cancer in the general population, mainly for the postmenopausal breast cancer risk, in the premenopausal in preventing breast cancer in premenopausal women, the data is a bit grayer. And it is important to understand that to decrease the risk to get cancer or to decrease the breast cancer specific and all-cause mortality risk associated with obesity in obese breast cancer patients, we need to have oncology nutrition intervention that leads to fat loss, not to just weight loss, because when the patients lose weight by muscle loss, what they obtain is not better prognosis, but worsened sarcopenic obesity. And really, oncology nutrition is not casual weight loss nutrition for the general population. Fat loss, not weight loss per se, decreases this risk, as sarcopenia is as strongly associated with decreased survival as high adiposity. And the second modifiable evidence-based nutrition-related breast cancer risk factor besides obesity is alcohol. And most know that excessive alcohol and binge drinking increase the risk, and maybe some assume that the risk is higher when the alcohol consumption starts earlier during the life of breast cancer, BRCA1 or 2 mutation carriers. But what most don't assume is first that the pinkwashing marketing campaigns built on cognitive dissonance that promotes products like wine that actually increase breast cancer risk. And I was mentioning in my lecture the VIP breast cancer survivor Sheryl Crow, who actually used her celebrity capital to increase wine sales. This was the first thing people don't assume. And the second thing most people don't assume is that 1 in 4 cancer patients meets the criteria for binge drinking, defined as more than 5 drinks per day. And we have scientific data that shows that like 1 in 3, 1 in 4 patients might need help with that. Maybe it is related to stress, maybe it's just a way to keep on living a normal life, but when it comes to BRCA mutation carriers, these women are like any other woman. Half of them are overweight and sedentary. 2/3 of them have a casual alcohol intake, and 1/3 of them smokes. And we know that smoking and drinking together increase breast cancer risk further. And the reason why these people don't, let's say, manage the risk and adopt the behavior that might help them decrease their risk of getting cancer is usually stress. And that is why it is very, very important after positive genetic test, it is important to have a psychologist on board, because these people usually might develop all sorts of behaviors that they use to cope with stress, but that these behaviors do not decrease their cancer risk. So while food and alcohol are the most used antidepressants, what we know is that sport is the most efficient, and scientific data shows that regular physical practice of exercise, ranging from whatever, from yoga to gardening, is both highly effective in coping with stress, and it is a behavior that decreases the risk of breast cancer in BRCA1 or 2 mutation carriers. Taking loads of dietary supplements, overeating fruits and vegetables, and not eating meat or forgetting all about sugar are attempts to regain control under stress, behavioral signs that needs to be addressed head on, or we just sweep the pile of dirt under the rug, and this dirt will keep on growing, leading to cancers. Working together with a psychologist after finding out a positive genetic diagnosis is paramount to prevent disturbed eating behavior like orthorexia and emotional eating. So how to prevent breast cancer in these people having mutations? Try to use sport, not food or drinks, to calm down. If you need to lose some weight, please make it be fat, lose fat, not just total body weight. And please try to keep away from smoking. Thank you.